All right, everyone, we're going to start our grand rounds. My name is Bindi. I'm one of the internal medicine chief residents, and I have the privilege of announcing both of our grand round speakers today. Our first speaker is Dr. Fiorella Perez, who has been assistant professor in the Department of Geriatrics and Palliative Care at the Icahn School of Medicine in Mount Sinai, New York City, since 2018. And she is incoming faculty for the Division of Geriatrics and Palliative Medicine at the University of Miami. Born in Peru and raised in Miami, Dr. Perez has earned her bachelor degree from the University of Miami and medical degree from St. George's University School of Medicine. She completed her internal medicine residency at NYCA Health and Hospitals Woodhull and her geriatrics fellowship at Mount Sinai. She has been the physician lead for both the Geri Align High-Risk Geriatrics Clinic and Transitions of Care Management Initiative at her institution, and is also involved in leadership development programs for medical students and fellows. In 2019, she established the Mount Sinai Morningside Geriatrics Clinic and played a pivotal role by designing clinic workflows, building a patient base, and precepting the first geriatrics fellows to rotate there. Since then, the clinic has grown to be a fully established site, providing comprehensive geriatric care to the Upper West Side community. Dr. Perez's work focuses on improving care transitions, reducing hospitalizations, and optimizing workflows and advancing geriatrics education. Since 2023, she has led and mentored the Geriatric Fellowship's annual quality improvement projects in transitions of care medicine. Her current project in the third year targets medication errors during hospital discharge, and her scholarly work has been presented at the American Geriatric Society and AGS annual conference. Please welcome Dr. Perez.
Thank you for that introduction. So today we're going to be discussing transitions of care management and readmissions. I apologize ahead of time. Of course, I'm coming down with a cold this morning. So like she said, I am a participant faculty here, assistant professor at Mount Sinai in New York, but I am incoming faculty, very excited to come University of Miami under Division of Geri and Palliative Medicine. Our objectives for today, as they were sent out, they're here for sake of time. We're going to identify and describe some patient, provider, and system level risk factors that contribute to suboptimal care transitions, describe some care transitions models and incentives for Medicare, and hopefully help you gain some strategies to improve the workflows in your clinic and department. So transitions of care, right, defined as the movement of a patient from one set of providers, level of care, a healthcare setting to another. In the smaller sense, you're thinking about inpatient, right? Any transfer of care, handoffs that you do from the ICU to the floor, from the floor to the ICU, and within providers or nursing and staff. For me and for this specific presentation, we're talking about in the bigger sense of outpatient. So those are across health systems, and your patients are being discharged from the hospital to the rehab, hospital to home, or from rehab to home, and what happens in that time. So why is this important? So by 2030, more people in the US will be older than age 65 than younger than they were than at age 5. So the changes in the population pyramid are changing over time. People are living older. So therefore, chronic health problems in older adults are becoming more prominent. And in that basis, then coexistent medical diseases more serious. Older adults are most vulnerable by research in this time. 40% of older adults experience 2 or more care transitions within 30 days of hospital discharge. There's a national study of Medicare, which showed that 22% of older adults experience care transitions of some kind, and half of those involve a single hospitalization with return home. And another half, or within that half, there's a complex sequence of other transitions. And so with all of this happening in these high risks, how to predict to intervene becomes very difficult. As you know, your patients are very individualized to what risk factors they have for us to target. And so I'm hoping to bring awareness a little bit to you guys about that. So what can suboptimal transitions of care lead to? And so in thinking of this and hoping motivating you to be participants, kind of if you can write in the chat, what do you think that that can lead to, right? Yes, of course, readmissions, rehospitalizations, but what else can that lead to our patients? And working as a community, both inpatient and outpatient, and looking at those variables, just type in the chat within the next 2 slides of what comes to mind. So 1 in 5 older adults are rehospitalized within 30 days. So it's about a quarter of our patients. 1 in 3 older adults are rehospitalized within 90. The cost, which is where the big factors come in here, of unplanned rehospitalizations to the Medicare program is estimated at 15 billion annually, right? And so increases the risk of adverse events resulting from poor care coordination among providers and healthcare entities, right? Because it really involves all of us having better communication. And what we need to discuss is hazards of care, right? The hazards of hospitalizations that happen to these patients, and some of the things that we can intervene on or be more aware of. And so medication errors, which is one of the big things that we all talk about, right? And so you're thinking about your patient that's being discharged, medications that were changed during their admission, what happens at the time of discharge, so they go to the right pharmacy. Do you call the pharmacy? How does the pharmacy know to stop giving them the medication when they have new or stopped medication? There's cost prohibitive medications, right, as well. So you think about that patient who was diagnosed with a pulmonary embolism and was giving Eliquis on their discharge, and the patient does not come to see their PCP or a clinic provider within a short period of time, but waits 30 days or 60 days. And by the time they come, you realize that the patient did not get the Eliquis because it was too expensive, or the Eliquis went to the wrong pharmacy, or the patient, for their own specific factors, has low health literacy and didn't know why they would need that, right? And so now, boom, you have an acute P again, and the patient goes back to the hospital for readmission for something that's very life-threatening. And so there are many examples that you can use in this way. New decompensated heart failure with an increase of diuretics, any of those medications, and this is how you become high risk in this period of time after a discharge. So there's also inaccurate or incomplete information transfer that can happen, right? And in doing so, you can have a delay of diagnosis, duplicative medical services. We have different electronic medical records across health systems. So if a patient gets admitted, I guess in South Florida, to a different hospital other than University of Miami, but then comes and sees a PCP, University of Miami, and we don't share EMRs, how do you know what happened, right? Because you have to do an imaging and the patient already got, sorry, you got to do an imaging and you already have that patient that had a CAT scan, but the patient, because of their health literacy, this cannot tell you what type of imaging they had. And so you don't know that they had a CAT scan, and you repeat a CAT scan. So now you've exposed the patient to double radiation, and you also are using excess source resources, right? By redoing some of the imagings that already happened. So barriers to CM as well, to TCM. So there's diverse needs across patients and caregivers, right? There's different education that's needed for specific population. Also within our providers, lack of provider education and feedback on execution of care transitions, right? So after a code, we debrief. Should we be debriefing and having more conversations about when a patient gets readmitted? Right? So there's difficulty communication with colleagues at previous or next visit site of care as well, right? Our lack of time in doing so, our lack of financial resources to address transitions of care issues, right? Which I'm also hoping to kind of bring awareness that we can have financial gain and support from a department for innovative workflows for this. So older adults are vulnerable to the suboptimal transitions of care, right? By their age alone, they're 4 times higher risk of hospitalization. They have longer lengths of stay, right? And so therefore they're susceptible to the hazards of hospitalizations. They have functional decline because they weren't taken out of bed to chair fast enough, right? And as you're preparing for discharge, they've been in the ICU too long. They have delirium while they're in the hospital. And so studies show that while they have delirium in the hospital, on discharge, that delirium can be prolonged. They can have a decline in their baseline cognitive status after a hospitalization. There's adverse drug events that happens, pressure injuries that also bring them back to the hospital, wound and care infections, bowel and bladder dysfunction. Now they have a Foley that they didn't have before. They didn't need to manage that at home, and now they have that. Malnutrition and dehydration. So As you can see, they're more likely to experience complications and require complex care after discharge. So risk factors for suboptimal care transitions. So thinking about this on your own too, right? At the patient level, we discussed some of them. And so what are some of the ones that we can think about at the patient level? We described a few already. Besides the age, right? It's their health literacy. It's whether or not they have any support at home. Are they living alone? Do they have a caregiver? As well as their unmet functional needs. Did we start home health aid at home after their discharge? They need more support for the IDLs and ADLs and the multiple comorbidities they have. At the system level, that where we can try to make some innovations, right? A lack of discharge of education. Are we educating enough at the point that we're sending them home about their medication changes or other factors, right? And are we failing to implement a proper care plan for the patients at the time that they are discharged? So thinking about things that we can target for our patients when they are going to be discharged, right? One of the main things of cognitive impairment. And so cognitive impairment adds to the complex care needs of up to 43%. So almost about half of our patients of hospitalized older adults in the US, and it's negatively affecting their patients' health, the quality of life, and unnecessarily increasing healthcare costs. So in this study, um, it looked at effects of alternative interventions among hospitalized, cognitively impaired older adults, and it put patients who were cognitively impaired among three different strategies or workflows interventions for post-hospital follow-up. One arm was just augmented standard care with standard follow-up with no other support, and then there was a resource nurse care workflow where a nurse care manager would follow up, and then a transitional care model. And the transitional care model consisted of a home visit and a phone call, right? And also follow up in the clinic. And the findings from this show that time to first rehospitalization or death was longer for the TCM group versus the ASC group, right? And so therefore it proved that yes, we can delay the rehospitalization or decrease the death risk, right, for patients, for this group specifically in this study, who followed a TCM workflow. So what can we do? So there are transitions of care management models to facilitate communication, and Medicare and our government system started to see there might be benefits in order to support programs to help reduce readmissions, right, and reduce financial costs. So the Affordable Care Act of 2010 provided financial incentives to improve care transitions and reduce rehospitalization rates. From the Affordable Care Act came the CCTP, or the Community-Based Care Transitions Programs, that promoted partnerships, provided financial incentives to CBOs or community-based organizations to test different transition care models, and gave them grants to do this. And then they were able to study among those different care models whether or not there was a difference for the readmissions or rehospitalizations. So for example, one study did show that rehospitalization rates increased tenfold when follow-up by PCP was exceeded for 4 weeks. So through these programs, they were able to try to identify what is the proper time and length after a hospitalization that a patient is at highest risk that we should be able to follow them up. So we know at least from this one study, it should be within 4 weeks. There is also the Hospital Readmissions Reduction Program, which is a Medicare value-based purchasing program. And that basically encourages hospitals to improve communication and care coordination in order to reduce avoidable readmissions. This, for us in layman's terms, is we get a penalty, the hospital or the ER, if a patient comes back. So there's various research now out there that is supporting transition care management and transitional care models to show that they reduce readmission rates and lower mortality, right? And so, for example, there are several TCM programs that have gone through randomized controlled trials and have been found to significantly lower readmission rates, achieving reductions up to 45%. Another study found that participants in a TCM program decreased their odds of readmission by 86%. And so there's various studies out there to prove this data, and I really encourage you guys to look into more of these. There's transitions of care programs on that same respect then that have now been coming up and springing up around nationwide. And if you've seen any of these on the side here, the National Transitions of Care Coalition is providing promotion about transitions of care and its benefits. There is the TCI, or their care transitions intervention, that's based on a physician that studied this and did research and had a grant for this as well and led this in Colorado. It is a patient-centered self-management program coordinated by a health coach. You have the Project Red, that's based out of Boston University, and it's a nurse, discharge advocate, and clinical pharmacist work together to coordinate hospital discharge and educate patients and reconcile meds. And they also proved through their project that they can decrease ER and hospital use within 30 days. Studies in general have shown that effective transitions of care use more than one modality, right? Meaning it's not just the patient goes to the clinic and gets followed up, but you can make a big difference in their outcome if there's a phone call as well, if there's a home visit, phone call, visit. There has to be more than one way of following up the patient in order to prevent readmissions. There's a CTM, if you've heard of that, that's the Care Transitions Measure, CTM3 and CTM15. This is basically how many questions are in a survey. It's a survey that's given to patients and their caregivers at the time of discharge or right after discharge to kind of survey and see where the need is lacking about education. So it would ask them about, did they think that they were reviewed the medications by the nursing at the time of discharge appropriately? Did they know when to follow up? Did they know who they were supposed to follow up with? And there's a series of questions as well that you can use in order to identify maybe where to focus on in your department. So speaking of caregivers, I don't think we focus on this enough, especially for older patients, right? Even if they go in independently to the hospital after a long hospitalization, they may have a decrease in their IDLs, ADLs, and now we have to bring in a caregiver that did never have responsibility over the patient before this admission. And so this study looked into that about their experiences. And it came up with 5 central themes. One, that the family caregivers had a different spectrum of readiness, willingness, or ability, right? Meaning you have to really kind of figure out where they're able to do within their own means. Number 2, they may have different goals than the patient, so we have to align their goals in order to make this work. Number 3, they were unprepared for the post-discharge medication management that comes with this. Number 4, they were encouraged to have an identity in this time because they were lost in what their identity was within all of this discharge follow-up. And last, they often assumed responsibility to navigate post-hospital follow-up appointments, tasks, and next steps, and they seemed lost or didn't know what to do with that. Another thing that we can target as well is, can we, right, because it'd be ideal that we can help all patients not get readmitted, but starting from one specific place, can we target patients who are higher risk to be readmitted and start there? And so in this research from 2024, they looked at predictors of hospital readmission rate in geriatric patients, and they looked at over 700 subjects. They did a comprehensive geriatric assessment. And in conclusion from this, they found that the main predictors for readmission at 1 year were a length of stay more than 14 days, a low albumin level, kidney disease, GFR less than 40, hypotension, a Charleston comorbidity index of more than 6, and a cardiovascular diagnosis. And so can we use risk factors like this to better identify which patients we need to target to prevent readmissions? So incentives. So from there, Medicare jumped on this wagon and said, well, this is costing a lot of money, and how can we help our patients? So in 2013, they came out a way in order to give incentives and pay our work for TCM workflows. They define a 30-day TCM period that begins at the day that the patient is being discharged from any of these specific places. And thinking about our settings, then, inpatient acute care hospital, which we can follow up in clinic, SARS, skilled nurse facilities, and also patients who are admitted to observation area in the emergency room. And so in order to bill appropriately, this becomes a partnership between inpatient and outpatient. The billing happens on the clinic level by the provider who sees the patient in the clinic, but it doesn't work and you cannot bill if these two things don't happen. And the first thing that has to happen is an interactive contact. So clinical staff must contact the patient or the caregiver by phone, email, or face-to-face. In my health system, the one I'm leaving, we have to contact them between 2 business days of discharge. And so we'll do a phone call, and I'm going to go into that. And number 2 that you need in order to bill, you need an appointment to be done within 14 calendar days. And so those 2 things are very important. Once those 2 things are done and the patient comes to the clinic, you can bill. And what's important too is the language here, that the phone calls within 2 business days. You think about patients who are discharged on a Friday, so you have really until Monday or Tuesday to give them a phone call and follow up, versus the appointment within 14 calendar days. And so thinking of what happens in a TCM, you have a patient who is discharged from the hospital or whichever setting, right? But then you want to identify them. And how will we identify them? The TCM initiative that I'm going to go into that we started here at Sinai, we identified patients with a telephone call note and a communication to the outpatient. And so now we know who was discharged so we don't lose them. TCM call, who will be responsible with TCM call? Those things happen so the patient makes it to see an appointment, and then when the patient comes into the appointment, that we're billing appropriately. And so ideally within my thoughts, right, this would be a successful transition to home. We improved their quality of life, we reviewed the medication, and we managed any high-risk symptoms or risks that can happen within that time period after patients being discharged. And so from the system level and from department level, and administration, in order to, we're all physicians, we want to make the best for our patients, and we don't want them to get readmitted or have any health decline. But also in the world we're in, we need to kind of back that up with financial gain for our department, and back that up in order so that they can support workflows like this. And so looking at here for everybody's view, are established and follow up and new codes for patients of level 4 and 5. This is the RVU and this is the payment rate. For TCM billing specifically, within 7 days, the RVU is higher than any of those, and within 8 to 14 days are also higher. So if we're billing appropriately for these patients, we are going to get financial gain for our department and support for these kind of workflows. So and lastly, in looking at TCM initiative, I reviewed data to apply all of this to our department in Sinai for November of 2023. 124 patients with a Jerry PCP were discharged, and only 60 of those had a TCM call. 25, so less than a quarter of those patients, had both a TCM call and a TCM visit. So how many patients did we miss to come and be seen post-discharge? And out of the 25 that were eligible to bill because they had both criteria, when they came to the clinic, the provider who saw them probably did not know to drop a TCM code and only billed 13. So we missed and dropped a lot of money on the table there for our patients, right? Miss patients to come in for their better care and decrease their readmission, and B, did not gain the money for our department to support this. And so I looked at what are the missed opportunities that we have here. How can we standardize our workflow as the health system kept growing and more clinics were out there? How do we increase the TCM appointments and the appointment adherence? How do we oversee the workflow, increase communication from inpatient to outpatient? And how do we assure providers recall the TCM billing code? So as the chief resident said at the beginning of this lecture, I've been part of a high-risk Jerry clinic embedded within our Jerry PCP clinic, and a subset of that was seeing TCM, but only patients that were at the most high risk by whatever criteria. But starting from the initiative and those numbers, I made it that we were standard that all TCM appointments came to our team so that we have a better way of keeping track of patients that get discharged. And in doing so, we had a handoff plan from inpatient to outpatient, a communication note that would be routed to our team in PCP. The outreach or the TCM call will be done by the inpatient discharge provider, usually was our fellow or our resident. And if they were overwhelmed, they would tell our teams that we would call the patient within the 2 business days. The TCM visit was standardized and done by our line team, and we knew already that we need to bill. But we also provided education to the department, to all outpatient providers, on what to bill and how to bill if they see a patient post follow-up. This is kind of like what well, this is what we use as our dot phrase for discharge communication note. It's different. The discharge summary is dropped as a telephone call note by our inpatient team and routed to the outpatient in order to specifically just say what complications happened, what were the discharge medication changes, what follow-up appointments we definitely need to make sure they get, who will do TCM call, and do they have a TCM appointment to make sure that is followed. And we created pools for each clinic site, so they were routed to the right clinical site pool, so they can follow up on that appointment. This is what they use, sorry for sake of time. This is what they used for the TCM call to make sure that they document they were called for CMS purposes and billing within the 2 business days. And also that the medication management or home health aid or whichever support they were supposed to do in that time was done, and remind them of the appointment. We created a TCM visit dot phrase as well. And in doing this, then the person who's seeing the patient and the outpatient can make sure they're reviewing the medication changes and just focusing on a post-hospital follow-up visit. And at the bottom, there's a hard stop to remind them of what billing codes to use. All of this was done, and then I reviewed back and presented the data and information to the American Geriatric Society conference this year in 2025, and it was presented on the presidential poster session. From my data, I was able to see that patients who received a TCM call and a TCM appointment were less likely to have a readmission compared to patients who did not. And the TCM codes billed and the total estimated TCM billing revenue increased in our practice by an average of 20% compared to prior months. And just to look at this data closely, this was the total TCM visits billed in our practice. In November of 2023, the total TCM billing visits per month was 24, steadily increased. There's a huge dip in June. We can only make an educated hypothesis guess that in June, people are graduating, people are going on vacation, we have less manpower and less support for TCM workflow. And that further, I think, supports the need for a good workflow and support system for this in our patients. I looked at the readmission rate for our patients in my project or initiative. And so the blue line represents readmissions for those patients that followed our TCM workflow, and the pink line represents readmissions for those patients who did not follow a TCM workflow. And as you can see, it was a lot less in decline for those who joined our TCM workflow. Sorry. The average 30-day all-cause hospital readmission rate in the US is 13.3%. And comparing that, I got the rate for our patients. Patients who received the TCM call and TCM appointment in our workflow was near that of 13.7%, while patients who did not follow our TCM workflow was 16.5%. Beyond that, to kind of wrap up, from after this that I did for about a year, we've continued to do that workflow, but also our geriatric fellows have done an annual TCM QI project as well. And the first year was focused on and spotlighted in our QI for our hospital, and one for the QI TCM for the fellows. And in the second year, they looked at high-risk screen questions to add to our discharge communique note, similar to what we've seen nationally and in other at the beginning of the presentation that can bring high risk, right? So they asked when the patient was being discharged, did they have a diagnosis of dementia? What was their frailty score? Did they have delirium? And did they have a new and or complicated diagnosis? And if any of these were a yes, they were offered an even earlier appointment post follow-up, and that they must have an in-person appointment. For sake of time, we know readmission risk scores. I just want to put out there, there's many out there that you might know for IM, LACE, and hospital. And I just want to wrap up in saying that I'm really passionate about transition of care, as you can see. And I want you guys to think about, instead of thinking of discharge, your patient is gone, left the hospital, and you're done. It doesn't end there, right? You have to think about it as a transfer of continuous management, because the care for your patient continues as they leave the hospital, and the communication among inpatient and outpatient, I think, really has to be at a superb level in order to make this successful for our patients.
Thank you so much, Dr. Perez. I think for the sake of time, we're a minute over. We'll hold the questions until comments until the end. And Ben, if you want to introduce the next speaker. Thank you very much, Dr. Perez.
Thank you.
All right, I can introduce our second speaker today. we have Dr. Mohammed Raja, who is our Assistant Professor of Clinical Medicine in the Division of Infectious Diseases at the University of Miami Miller School of Medicine. Dr. Raja completed his medical school from Gulf Medical University in UAE and then completed his residency in internal medicine at the University of Alabama. He then pursued fellowship in infectious disease and subsequently transplant ID at the University of Miami Jackson Memorial Hospital. And he is currently serving as faculty. His clinical practice and research efforts are focused on transplant infectious diseases at the University of Miami Hospital, as well as the Sylvester Comprehensive Cancer Center, with the primary focus on infections in post-hematopoietic stem cell transplant recipients, as well as invasive fungal infections. He has authored several papers on the impact and clinical outcomes of COVID-19 infection in transplant recipients and on breakthrough invasive fungal infections among high-risk cancer patients. He is an active member of the American Society of Transplantation and Cellular Therapy Special Interest Group in Infectious Diseases. Please welcome Dr. Raja.
Okay. Hi, everyone. Thank you for having me today. I'll be talking about fungal prophylaxis in heme malignancy and stem cell transplant patients. Doing transplant ID at these are the patients that we usually come across a lot, so I thought it would be important to just give an overview of fungal infections, especially if you're working at and Sylvester, you are bound to come across these patients at some point. So let's see here. So I have nothing to disclose. Obviously a big topic, but given the time that we have, we'll try and get as much as we can. We'll talk about risk factors associated with invasive fungal infections among stem cell transplant and heme malignancy patients. Go over some recommendations for prophylaxis in these patients, and also understand a little bit about incidence and the risk of breakthrough in patients who are on prophylaxis. So let's start off with a case. This is a patient that we saw about 6 months ago at is a 78-year-old male with prior history of allo stem cell transplant who then had relapse of his underlying AML. He's refractory. He's had multiple lines of chemotherapy. His last one was cladribine plus low-dose ARC. He presented 2 weeks after his chemo with a few days of fevers, weakness, joint pains, and new onset of skin lesions. Patient lives in Miami. He's originally from Puerto Rico. No recent travel, no recent sick contacts. When you start talking to him about his social history, his activities, he mentions he started mowing the lawn a week ago or so. And he also used to smoke marijuana, but he hasn't in the last 2 months. His home prophylaxis includes acyclovir for HSV-VZV prophylaxis, Bactrim for PGB prophylaxis for his regimen, and Levaquin for his neutropenic prophylaxis, and he's on isavuconazole as part of his fungal or mold prophylaxis. On admission, he is pancytopenic, he's profoundly neutropenic, he's thrombocytopenic, kidney function is stable. He has mildly elevated LFTs, but his bilirubin is within normal. This is a picture of his skin lesions. He developed these skin lesions a few days prior to admission. They are scattered all throughout his extremities, his trunk. They are erythematous, very warm and very tender to touch, maculopapular. We also decided to get a CAT scan of his chest. As you can see, he has these bilateral multifocal nodular ground glass opacities in multiple lobes of his lungs, almost like a halo sign, but not entirely a halo, not the textbook halo yet. So a skin biopsy was done of one of those lesions, and it came back positive with branching hyphae. And this is a picture of what it looks like under the microscope. And as you can see, these arrows, they point to hyphae in the dermis, invading the tissue dermis, as well as hyphae within blood vessels. So that indicates there's active angioinvasion. So this prologue brings us to our topic of the day, which is invasive fungal infection. So I thought in terms of incidence, I thought I'd start off with a sort of a map of the world when it comes to the reportable mortality with invasive fungal infections around the world. So reportable mortality differs. There's regional variation, geographical variation. There's variation when it comes from to institution. Also, the way they report mortality is also a little different. Surprisingly, some regions have not even reported their mortality, which is kind of scary. But mortality is significant, approaching 50% or even higher in certain regions. So what is the incidence of invasive fungal infections in stem cell transplant and heme malignancy patients? So in the world of stem cell transplant, we have slightly more concrete data. The incidence is anywhere between 6 to 11%. It's higher amongst allogeneic recipients as opposed to autologous. In the world of heme malignancy, data is more variable. It depends on the type of underlying disease, the timing of chemotherapy, whether it's during induction versus consolidation. Overall, we know incidence is higher in AML MDS patients as opposed to lymphoma, as opposed to myeloma. We also know in terms of IFIs, the most common pathogens are usually Aspergillus, followed by Candida, then Mucor, and then other molds. And like I mentioned earlier, mortality is pretty significant, can be as high as 50% or even higher, especially in these immunocompromised patients. This is a figure from the Transnet data, which was a multi-center surveillance of different transplant centers looking at IFI, incidence of IFIs in BMT patients. As you can see, Aspergillus was the most common, followed by Candida and then other mold species. Incidence is highest in the first 6 months of transplant, just as a reflection of your peak of your net state of immunosuppression. So what are the important risk factors when it comes to invasive fungal infections? So there's many risk factors, there's many categories. There's patient-related, such as advanced age, underlying diabetes. There's disease-related, like we mentioned, AML, MDS, higher risk. Patients who have allo stem cell transplant, GVHD patients, patients who've had multiple lines of chemo, they're not in remission, they're refractory disease. Those who have prolonged neutropenias, patients getting high-dose steroids, T-cell depleting therapies. And also environmental factors are very important, such as high-risk occupations, like somebody that's farming, gardening, landscaping, etc. Those who smoke marijuana, that's an important risk factor for environmental exposure. So just as a reminder regarding the basic pathophysiology when it comes to mold infections, most of these molds, Aspergillus included, they live in the environment as spores. These spores tend to be dormant in dirt and soil and vegetation. And then you inhale these spores. Your portal of entry is usually the sinonasal passages. And then they make their way down into your lungs. And in immunocompromised patients, this is where angioinvasion and this is where dissemination happens. Hence why your white cells, your neutrophils, are so critical when it comes to preventing this dissemination. Okay. This is just a reminder that cannabis, marijuana is a risk factor for invasive aspergillosis. Those leaves can have mold, the spores on them. So it's important to talk to your patients about this. Okay, so what about prophylaxis? So who needs mold prophylaxis? Who is at high risk for mold infections that deserves or should be considered for prophylaxis? So high-risk MDS, AML patients, especially if they're undergoing induction chemo, heme malignancies in patients with prolonged, profound neutropenias for more than 2 weeks, allo stem cell transplant patients, especially if they're receiving a cord transplant, haploidentical transplant, those who are delayed engraftment with prolonged neutropenia, someone with severe underlying GVHD that's getting high-dose steroids plus multiple other immunosuppressive agents, someone with a prior history of fungal infection that is now going to get chemo or transplant, etc. Also, CAR T patients, certain CAR T patients with risk factors, such as those with high risk or high grade CRS, getting high-dose steroids, plus multiple other immunosuppressive agents. All in all, these are patients who are probably the most immunosuppressed, and they're at risk for all sorts of opportunistic infections, including invasive mold, invasive fungal. So what are our most commonly used prophylaxis agents? As I'm sure most of you know, triazoles are the most commonly used ones, that they form the backbone of our commonly used prophylaxis agents. Of the triazoles, POSA probably has the most data, strongest data when it comes to prophylaxis. It's the one that most guidelines, most experts tend to favor. Voriconazole is an acceptable alternative. Data tends to be less in terms of prophylaxis as opposed to POSA, but it is an acceptable alternative. Remember, Vori tends to have slightly more drug interactions, more issues with LFTs, QT prolongation, etc. Then you have isavuconazole, sort of newer on the scene, primarily studied in treatment, but we do have data for prophylaxis as well. Typically, an alternative agent, especially if you're trying to avoid drug interactions or if you have a patient with prolonged QT, this will be a good alternative in those scenarios. In terms of other classes, echinocandins, like for example, mycofungin. Is there data? There is data for prophylaxis with echinocandins as well, but it's limited, smaller studies, but it has been successful. And then you have amphotericin, which we tend to avoid because it's very nephrotoxic. So this was a table looking at the landmark clinical trials that studied posaconazole as prophylaxis. So back in 2007, there were these two landmark clinical trials that looked at POSA prophylaxis in high-risk AML, MDS, as well as allo GVHD patients. In both studies, POSA showed a statistically significant reduction in IFIs, as well as an overall survival benefit when compared to Fluke or ITRA. On the other hand, when voriconazole was compared to Fluke and ITRA in two different studies in allo stem cell transplant patients, although there was a trend to fewer IFIs in patients who were on voriconazole, it was not statistically significant. That being said, those two studies had issues with study design. They weren't powered correctly, and also had issues with selection of high-risk IFI patients. That being said, yes, voriconazole is an acceptable alternative. It's not that you can't use it. The data that we have is stronger with posaconazole when it comes to prophylaxis, just the way it's been studied. Okay. Busy slide, but just wanted to go over really quickly when it comes to antifungal spectrum of activity. All three azoles tend to have a very similar spectrum of activity with the notable exception of mucorales. Remember, mucor is not covered by voriconazole. It is covered by POSA and isavuconazole. I also decided to add a little star next to fusarium, just a little bit of foreshadowing. Even though it says here all three cover fusarium, it really depends on the subspecies of fusarium. It's very variable. So I would say this is more plus minus rather than plus plus. Okay. So going back to our patient that we talked about, what were his risk factors for invasive fungal infection? So obviously advanced age, his underlying history of stem cell transplant, his relapse of his leukemia, the fact that he's been on multiple lines of chemotherapy, heavily immunosuppressed, prolonged, profound neutropenia. He was mowing the lawn, an important environmental risk factor, and also prior history of marijuana use. Those are all important environmental exposures. Okay. So what happened with our patient? So his blood cultures came back positive for mold, which we then sent to our special fungal testing lab in Texas, and they identified it as a Fusarium species with subspecies falciforme, which was quite resistant to all the azoles. And this then brings us to our next topic, which is breakthrough fungal infections, especially since this patient was on mold active prophylaxis. So what are breakthrough infections? Breakthrough fungal infections occurring in patients who are on active mold prophylaxis. Is there data on this, especially comparing the three major azoles? Yes, we do have some data. There is, like, for example, this retrospective cohort study that looked at 200 plus patients where they compared rates of breakthrough IFIs on the three major azoles. And this study also showed that there was an increased incidence of breakthrough IFIs in patients who were on isavuconazole. Notably, majority of patients who have breakthrough were the ones that were likely to be neutropenic and less likely to be in complete remission. That being said, is isavuconazole one of those that has a higher risk of breakthrough IFIs? This is something that's been of interest. There is some real-world data looking at this. There are studies looking at high-risk AML, MDS, and stem cell transplant patients. The incidence of proven probable breakthrough IFI on isavuconazole has been around, in those studies, reported between 6 to 8%. Median time to breakthrough was more than 14 days in most of those studies. Median serum concentration in those patients with breakthrough was more than 3, which is an adequate level as per the manufacturer's guidelines, as per the initial trials that they did for isavuconazole treatment. So it was those levels are therapeutic. Aspergillus was the most common pathogen in the breakthrough patients, and majority of these patients who had breakthrough were the ones that were more likely to be neutropenic with prolonged neutropenia and more likely to not be in complete remission. So that being said, we were curious to see, we also use isavuconazole. We were curious to see what is the incidence at UM in our institution when it comes to breakthrough with isavuconazole. So we did our own retrospective study with 100+ patients. We included AML, MDS, and patients with prior stem cell transplant. Our incidence of proven probable breakthrough IFI was around 12%, which was higher than compared to those other studies that I talked about. It's hard to compare head to head to the studies. They're not exactly the same populations. We did, however, our study did include more patients that were in the relapse refractory status, and our patients tended to have slightly longer median duration of neutropenia as opposed to those studies. Interestingly, our study had a median serum concentration of more than 3 of isavuconazole in all patients, which means that they did not break through because of subtherapeutic levels. Majority of patients that had breakthrough were neutropenic as well, like those other studies, and our all-cause mortality was close to 50%, pretty significant. So given that variability and incidence amongst different studies, we were then curious to see if we could do a systematic review and meta-analysis of the available studies that were out there. We included more than 900 patients. The calculated pooled incidence of proven probable breakthrough IFI was close to 7%. Aspergillus was the most common species in all the breakthrough patients, then Candida, then report, and then other species. All studies that reported isavuconazole levels reported levels greater than 1, which indicates that these breakthroughs were not because of subtherapeutic isavuconazole levels. Then that brings the question, are these breakthroughs because of resistant pathogens? The problem with that is not most studies don't actually report resistance testing or susceptibility testing, simply because it's not always easy to isolate mold from cultures. Cultures they don't always grow on cultures. Even in our own study, we had 4 cultures positive for mold. Of those 4, 3 were Fusarium, which we were able to test, and they were resistant to isavuconazole. The 4th mold was an uncommon black mold, which when we tested for susceptibility, it was actually susceptible to isavuconazole, which then brings the question that this patient still broke through on isavuconazole. So hence, is it a part of also the host immune system that plays an important role in this? So obviously, there's a lot of research gap here. There's a complex interplay between the host, the pathogen, and the medication itself. There's just an area that needs to be further studied, I think. But at the end of the day, I think the most important message would be no prophylaxis is 100%, right? Especially if you have such an immunocompromised patient like the one we presented, someone with stem cell transplant, multiple lines of therapy, profound prolonged neutropenia, presenting with skin lesions, lung nodules, fevers. You should always keep this in the back of your mind, regardless of what they're on. Also, another important, I'd say, takeaway would be when you are taking a history, make sure and try to go over environmental exposure. So important to ask about activities, hobbies. Are they gardening? Are they farming? Do they have a rose bush that they're trimming? Are they smoking marijuana? Marijuana usage is an important exposure risk factor for invasive aspergillosis. So a lot of times we forget about it. We're in a rush, we skip over it, but these are important things to ask our immunocompromised, neutropenic patients, chemo patients especially, because that's an important risk. And that would be it. Thank you very much.
Thank you so much, Dr. Raja. That was very helpful. I'll go to Dr. Lakakis in a moment. If I can ask you, you showed what would look like MICs, I guess, for those 4 drugs for that patient. What did you end up doing for that patient who had resistant breakthrough infection?
So we had ambisome, but unfortunately that patient, he passed away. Yeah.
In other situations, I mean, like, if it wasn't for that unfortunate event, you would have had to go with something like amphotericin and dealt with the consequences?
Yeah, that's what we've done. Unfortunately, there's no other, or in certain scenarios, we've also looked at compassionate use with novel antifungals that are out there, but yeah, those aren't always easy to obtain. Yeah.
Hey, Dr. Lakakis, are you available to unmute, or you want me to read the question for you?
No, I will do. First of all, we are indebted to Mo for his help with our complicated patients. So I noticed more breakthrough IFI on isavuconazole. Is there any mechanism that, because the spectrum is approximately the same, is there a mechanism of resistance to ISA that is not relevant to POSA? Why POSA has less?
Yeah, we don't know. So that's a great question. So we just don't know. You know, there's a lot of theories, a lot of these studies. Remember, you're using isavuconazole in patients who are probably very immunocompromised, they're very neutropenic, they're on targeted therapies, right? So a lot of these patients are, let's say, midostaurin or gilteritinib, where you don't want to use POSA or VORI just because of QT prolongation drug interaction. So these patients, to begin with, are very susceptible to fungal infection. So that's one. The other thing is, is isavuconazole sort of causing this increase CYP51A gene mutation that leads to increased efflux pumps that affects isavuconazole? We don't know. We don't know. Yeah, that's the truth.
I remember another medication, fosmanogepix.
Yeah, so that will be a novel antifungal, right?
Where is this?
It's compassionate use.
Thank you.
Thank you. And Dr. Shukla also commented in the chat about both genotypic and phenotypic mechanisms not being well understood. I think you highlighted that as well. Any other questions for Dr. Raja? Some comments complimenting you on your help with their team. Any questions for Dr. Perez? I saw several folks on the call who are very involved in transitions of care. Dr. Perez, I know you're a geriatrician and focus mostly on the older population. Your data was largely in that sphere. We also, of course, have a lot of chronic disease patients under 65 and are not Medicare patients. How closely do the data mirror or reflect in younger populations if it's been as well studied? And of course, more complicated when you can't necessarily assure that a non-Medicare patient who is seen in the hospital is insured in the correct way to get outpatient care in your same health system. So can you tell us a little bit about if you've had to navigate any of those? If you have, I know you focus mostly on geriatrics, but just wondering in the younger folks.
Yeah, I haven't navigated those situations myself. Along the research information I've got, though, most of the things are targeted over our chronic patients, our older patients in the Medicare. I think as far as the incentives and things to kind of promote this kind of workflows in the hospital setting, right? We know that administrative wise, again, like on the humanitarian and doctor wise, we want all to do well, but I think the incentives are coming from there. I didn't see in my research or in my view of the difference of these programs out there anything for like the younger population. I imagine that there are different QI or committees in general about readmissions, like in Sinai Hospital as well, reviewing readmissions in a general sense, right? Surgeries and what happens post-op and all of those are not just the older populations, but specific data I don't have.
Well, that's a perfect transition to our QI, one of our QI experts, Dr. Sosa. You had a question?
Yes, thank you, Dr. Perez, for a wonderful presentation. We do have an ADT, admission, discharge, transfer nurses that do routine phone calls to all our patients at 7, 14, and 30 days to prevent readmissions. We have opened some post-discharge clinics with some nurse practitioners, but we will be happy to partner with you when you come to develop a more robust system for transitions of care and readmission prevention. So I'll be reaching out.
Happy to have those conversations. At Sinai, they do have nursing that follow up as well. And a lot of, to be honest, a lot of the programs out there are nursing led, but there's some that are provider as well. There is a big one at University of Pennsylvania that they offer even free workshops, I think like 2 hours online to University of Pennsylvania, a grant that they had to back in the day, and that's still running. So there are different health systems out there that are trying to promote more awareness of this. And then in our health system, the nurses do also, there's a transitions of care co-management that they also, I think, get flagged for follow-up and phone calls. But our geriatric specific department and for our specific patients, we've kind of made it for the workflow will function different for us. And so the TLCCs here for the nursing that do, I think what your guys kind of do too for the follow-ups, when they see that the patient has a Jerry PCP in this department, they will bypass those patients because they defer to us to follow up on those. So then it gets triggered this way, different workflow for Jerry patients, yeah.
Thanks. And Dr. Brown mentions importantly that Medicare is not just age, but also chronic conditions. But of course, we have a lot of chronic disease patients with commercial insurance as well. Any other questions or comments for either speaker?
I have a very quick question. I'm Raúl Cortiñas, the physician advisor, and I am very interested in this presentation. So thank you, Dr. Perez. I have a quick question. Did you notice any difference on this transition of care when you start the safe discharge planning between where do you start the process, at the moment of the admission or at the moment of the DC order is placed in the medical record? And the second part of my question is, did you notice any difference on the metrics at the end?
So are you saying that we start intervening at the moment they got admitted, or?
Yes. Yes. Did you start the intervention at the moment of the admission, at the moment of the hospitalization, or did you start the intervention at the moment that the provider entered the DC order?
Okay, so the workflow starts the moment the patient is being discharged. So there is a lot to say to, maybe preparing patients ahead of time before the discharge is another intervention. We didn't do that preparation. It was more towards at the end. Once the patient is being discharged, that is where the intervention started. The provider who is who's giving them a discharge. So in our case, that would be the geriatric fellow, and in some cases for the medical teams, the medical resident on the geriatrics team, they would drop at the moment that they're doing a discharge summary. They will also drop a telephone encounter note with this discharge communication note, so that is routed to the outpatient teams. So that's our notification of discharge, so this patient is not lost. And so that's where the workflow would start. And yes, definitely. And from the data that I got from doing this and presented at the conference of AGS this year, it really did show a change in the metrics. It really did show our numbers spiked in the amount of TCM visits we had in the clinic, the number of times that the provider with those successful 2 components that we're able to bill also spiked, and the readmissions also decreased. So we were very fortunate to be successful in doing that, but still a lot of room to grow. We're still missing a lot of patients, and it's not a perfect system, but the more patients to capture, the better.
Thank you.
Thank you. Thank you all for joining. Please note the CME and MOC in the chat, where you can get both, as I said, CME and MOC. We'll be back to live next week. And Dr. Weiss will also be back to helm the ship next week. So thank you all for joining, and we'll see you next Wednesday.